Hello, my name is Jim Kohner. I'm a periodontist and I practice in Scottsdale, Arizona. It is my pleasure to be here to create this program for the Global Institute. We're going to be doing two programs here on clinical crown lengthening. One of them is on aesthetic issues, and this particular one that we're doing now is on functional mechanical issues, mostly around posterior teeth, to help you with more predictable crown and bridge. My goal in the course is to help you to learn how to do crown and bridge work faster, easier. Yes, I suppose that's part of it. Less costly, that's part of it too, because you won't have repeated impressions and repeated remakes. But also for me, and the reason that I'm putting together these courses is because I want to help you to do it better. I'd also like to talk today about a little different thought process. We all know about the term clinical crown lengthening, and for the most part we have a pretty good idea of what it is. And today I want to introduce another way of looking at that issue of clinical crown lengthening, namely the new thought process that I want to talk about is to think of it as gum shortening, the path to restorative success. Let me start out with a true story. Let me start out with the story of Harriet. You know, in my office, when somebody comes in, normally I meet them in the consultation room and I get to introduce myself and say, hello, welcome to the office. How can I help you? Or do you know why your dentist sent you over here? Something cordial, something as a way to more or less break the ice. Well, as I walked into the room with Harriet, and before I could say hello, before I could introduce myself, she said, I am a medical malpractice attorney, and I want to know, did my dentist do this to me? Well, let me tell you what they did. Harriet was 32 years old at the time, a generally healthy mouth, but she also had too much gum tissue in a lot of areas. So she didn't have much tooth here for the dentist to have a crown be retained properly. And you can see on the x-ray a rather small amount of tooth showing, even though she has quite an adequate root structure. So her crown fell off 3 different times, and she finally got frustrated and didn't go back soon enough. And as you can see here, the tooth decayed out and eventually was lost because of excessive decay. And it's really a shame because this was a good tooth that could have been salvaged easily if the gum shortening was done the first time around. So let's talk about what's involved with these issues. Gum shortening can be very valuable in helping you to have less stress because you're going to have fewer failed impressions and fewer remakes. Therefore, it's going to help you to increase your earnings and have better clinical results. And if you have all those things, what else are you going to have but happy patients? Harriet was not a very satisfied patient. Needless to say, she did not go back to that dentist. In the full-day hands-on courses, I always ask people, what are you interested in learning today? And here's a list of some of the things that they have said. It's the things that I'm sure you've experienced if you've done any amount of crown and bridge dentistry. The need to retake impressions, sometimes more than twice. The unexpected issue of red gingiva or sore gingiva around a crown. Why would it be there? Maybe the crown was placed too far under the tissue, and those are the exact issues we're going to talk about today in this program. You already saw another issue, but it's been mentioned at the seminar, crowns falling off, remakes, cosmetic enhancement. Well, of course, we address that mostly in the other program that we're doing here for the Global Institute. And of course, the all-important issue, and some people know the term, they wanted to learn about biologic width. And that's what we're going to focus on here today with some examples and also some discussion of what biologic width is all about. My objectives in the functional course now are to help you learn to manage, or at least to understand if you choose not to manage it, both hard and soft tissues. And what does it take to control those and prevent problems and prevent the tissues from causing these problems? Well, one thing that it takes is a very close understanding of biologic width. You hear the term. Today we're going to talk about it in great detail. Also, to increase your diagnostic acuity and to start looking at x-rays differently. You already saw on Harriet's x-ray that I explained that there was plenty of tooth structure. If we got the gum out of the way, her crown would have had better retentiveness. And another thing that I want you to think about, if you're a restorative dentist looking at this program, is that I do want you to be involved with your periodontal colleagues. You know, they're intimidated. And if they know that you're taking this course and that you're looking to do some of these things yourself, then they're going to be more intimidated. So I think that it's in your best interest to keep involved with them. Let them know what you're doing. Let them know what you want to learn about. Let them know you want to do some of this yourself. But be sure that they know also that you're going to still want to be on their team. Because what's the bottom line of all this? What are we here for? We're here because we want to talk about everybody being happier and more successful. So if we're talking about long-term stability, and we're talking about the posterior, and we're talking about issues like Harriet that you've already seen, then there are two issues that we want to focus on in this program. One is the mechanical advantage that you saw lacking with Harriet's molar, and then biologic compatibility, which is where we're going to talk about all the measurements composing biologic width. So from a mechanical standpoint, we want to talk about sound clinical judgment versus heroic crown and bridge. One of our colleagues chose to use this tooth as a distal abutment for a posterior bridge. I don't know what he was thinking, but it seems clear that the only thing that was holding in this bridge was that post. You could even see the decay on the x-ray and some buildup material that they had placed there. This bridge fell off many, many times before Ashley actually made it to my office. She had, not surprisingly, gone to a different dentist by then, who referred her and said, "What can we do?" And as it turned out, we could do nothing to use these teeth except to give her implants instead. So if you're trying to avoid heroic issues and you want predictability, then let's look at some of the things that gum shortening can help you to accomplish. Gum shortening can help to avoid what is often referred to as premature decay or premature failure. If we look at Richard's tooth here, it's split right down the mesial root. I think you may be able to see that on the x-ray. And it split, as has been said, prematurely. You know, the American Dental Association claims that crowns, on average, only last for 7 years. And that is a little disappointing. Well, you could say it's good because we get to do more dentistry, but I think from a consumer patient standpoint, that is disappointing. Richard's failed because his crown was placed 100% on the amalgam buildup on that mesial aspect. And the buildups just simply are not stable. And as a result, the crown or the bridge can wiggle, causing fracture or premature decay. And that brings us to the issue of what is called ferrule, or we term it ferrule effect. I wasn't sure exactly what the word ferrule meant, so I went to the dictionary. And what we found in the dictionary is that ferrule was referred to as a ring around the end of a post to prevent splitting. Now you've seen that at the bottom of a cane, for instance, where there's a metal ring around it so that the end of the cane wouldn't wear out, or a rubber ring around it so that the wood or the metal of the cane is not striking the ground. Another thing where we've all seen is a short metal sleeve at the end of a tool handle, a shovel, a garden rake, a spade. All of these things help provide stability in the same way that a tooth preparation is meant to provide stability for the crown, to act as a retainer. Here's Ashley's tooth. No retainer, no retention. Here's an excellent tooth preparation from the laboratory. You can see the difference, obviously. Having at least 2 millimeters of solid tooth here is what is referred to as the ferrule effect. There have been a few articles recently that have driven this point home for us. This is an article where they were studying the fracture resistance of endodontically treated teeth. And our colleague in Turkey was studying extracted canines, and they prepared them to have different ferrule effects of 1, 1.5, and 2 millimeters. This part of the tooth right here, this part right here is the ferrule. And how tall that amount of tooth structure is was studied. And what they found with a ferrule of 1, 1.5, or 2 millimeters, notice that there's more solid tooth structure here being included in the crown. This is the post, and here's the core buildup. But we're talking now about the natural tooth that the crown margin will reside on. By studying the different sizes of ferrule effect, what he found out was that they had better fracture resistance on these extracted teeth if they had a 2 millimeter zone of solid tooth structure. Another study by Dr. Tan here in the States at the University of Iowa studied the same idea of varying ferrule heights and the different configurations of these heights on 50 extracted central incisors. And he studied a ferrule of 0.5 to 2 millimeters, but not particularly uniform. It could be very irregular. And then he studied a 2 millimeter ferrule with very nice uniform preparation. And what did he find? Better fracture resistance with a uniform 2 millimeter ferrule. So if you'll notice here in his diagram, here's the amount of tooth structure, here's the post and the core buildup, but the crown needs to have retention on natural tooth. So he found that the 2 millimeter ferrule was the best, better than a non-uniform ferrule, and of course non-uniform was better than nothing. So both of these studies show us that we need, beyond our buildups, a certain minimum of tooth structure to provide stability so that there is no wiggling, no premature loosening, no breakage of the cement seal, and we have better stability, better longevity. Here's an example from a patient who had a result that was very unfortunate. This bridge was made for him just 3 or 4 years ago. But is it a surprise to any of us that the bridge loosened up, resulting in significant decay all the way up and around the post, when he had zero ferrule effect on these teeth? All that was holding this bridge in were these 3 posts. It's not a surprise, but this is a complete violation of the principles that we've been talking about, and an unfortunate consequence. Here's another situation that illustrates very nicely what a ferrule effect is and why it's needed. If you'll take a close look at the x-ray here, I don't know whether or not you'll be able to see that there are grids on the x-ray. But I can see the grid right here, and there is 1 millimeter of tooth structure above the bone, maybe a little more than a millimeter. You can see clinically no tooth structure, all buildup. So as we've just discussed, if you want the crown placed on this tooth to be long-lasting, you need to shorten the gum and you need to shorten the bone in order to provide unprepared, unbuilt up natural tooth structure for the crown retention. Here's an example also from the laboratory of very limited tooth structure, very limited ferrule effect, and this is the kind of tooth preparation that I see when people come in with a story of crowns falling off. And this is why everybody in the audience has raised their hands, that they've all seen it happen. It's unfortunately very common, and the goal I have for you today is to walk away with information about how to avoid that. Another example of how you can create problems. If you can't see your finish line well enough that you can get an impression that shows that margin 360 degrees around your prep, then you're going to have problems of one sort or another. Here's an example of one where you can see the margin 360 degrees and you have much better stability and predictability. It was very interesting to me a number of years ago before one of my presentations when I sent out a survey to find out what people were feeling about their frustrations with crown and bridge dentistry. I sent out 200 surveys and I got back somewhat better than 50, which I'm told was an excellent result. And here's what people were saying: that they're frustrated, 40% of them, frustrated with having to retake impressions. 50% bisulcular bleeding. Now, we've all seen that. Almost 60% said they're frustrated when they get preparations going down into deep sulcuses. Well, these are all the problems that I alluded to in the very beginning, where if we could help you to solve these problems, you'd have more profitability, fewer remakes, and happier patients. A significant percentage stated that patients refused referrals for crown lengthening referrals. Well, that's okay. This is a matter of learning the benefits and the values for the patients and helping to maybe find more ways to communicate how these procedures will be helpful. Because if people understand them, they're going to want them done. And I have other dentists that say they just don't have people turning them down because somehow or another they've explained it. And it was very interesting to me on the survey that 88% of the people responding said that yes, unfortunately, they were aware of prepping into the biologic width. So if we're interested in learning today about what it's going to take to have better stability and better long-term stability for our crown and bridge restorations, then we not only have to understand ferrule effect, but we also have to understand the biologic compatibility that we've referred to as biologic width. There are a few things that make up the biologic width around teeth. One of them is the bone crest. Understanding where the bone is a very important parameter in planning the marginal location of your restorations. Another is the CEJ, or in the case of a restoration or a fracture, where is the apical extent of the fracture or the previous restoration? And in addition to that, we have a healthy gingival margin, which includes epithelial attachment and sulcus. If we go back to the original article from the 1960s that explained all this to us, we find that the numbers that were given to us, and I'm sure you can't read the numbers, so I'm going to tell you what they say. The connective tissue attachment, they say, was on average 1.07 millimeters. The epithelial attachment, 0.97, and the sulcus, 0.69. Today, to make it simpler, and because our probes don't measure in hundredths of millimeters, for all intents and purposes, the commonly accepted dimensions are 3 millimeters. One for connective tissue, one for epithelial, soft tissue attachment, and then 1 millimeter for the sulcus itself, for a total of 3. The 3 of these together comprise biologic width. And I will tell you that the body has these numbers memorized, and therefore so should you. It was very interesting to me when I went to see a colleague and I decided to photograph some of his skull that he had in his office. No. When I went to a colleague's office and I wanted to photograph his skull so that I could have more illustrations in my presentations. And I observed, interestingly enough, that the skull had calculus on the tooth. And in measuring it, look what it was. Exactly 3 millimeters. The body knows its own biologic width. And it's very important to know that it knows. It also knows this around implants. And for those of you that saw the other presentation, you'll know that we made the same point there as well. But if you look at an implant and the collar is kept outside of the bone, when that implant is restored, the bone stays exactly where it was because the body can have that biologic zone attached right here on the collar. It knows. However, when implants are placed lower, there seems to be something about the slight gap between the abutment and the implant head. So that even though right here we start out with bone up to the top of the implant, once that healing head is removed, the soft tissue attachment disturbed, the bone then goes down lower because it needs to reestablish biologic width on the collar of the implant. Here's another example. And even though this healing head was a little bit loose, note that the implants are placed at the bone crest. And once the healing heads are removed, and once the crown is placed and an abutment is on there, the bone level retreats because the body knows and is reestablishing biologic width. Let's look at what causes problems around natural teeth and how it all relates to biologic width. Altered passive eruption is a term that we've heard, or some of you call it delayed passive eruption, which just means that there's too much gum around the crown of the tooth. But you see, that's because there is bone underneath the gum tissue. Here on the palatal side, a lingual exostosis. Over here on the lingual, the internal oblique ridge. And what this tissue does, what this bone tissue does, is it forces the soft tissue higher, resulting in smaller teeth, as you can see here for Nicole. So the preparation that this dentist was trying to make was too far subgingival. There was a previous restoration which guided him and forced him to be subgingival, and he felt that he could not get an adequate preparation without violating the biologic width. So here's the perfect example. Large amounts of tissue, high up. I tell people it's like having a turtleneck that's up to their ear sometimes. And there's what's causing it, the large, bulky bone. So if you want to have more tooth exposed for your restoration, then you have to remove the soft tissue and the bone. So here you can see only 3 weeks after surgery, Nicole's tissue is well healed. And what does she have? She has tooth structure showing so that now the dentist can restore this tooth predictably. And right under here you can see the buildup, the discoloration of the tooth. Well, maybe you can't see it, so that's why I'm pointing it out to you. So after only 3 weeks, the tissue looks excellent. So I hope that by now you're starting to get some sense that the body understands the biologic width, that we're looking at 1, 2, 3 millimeter increments, and these things will come back to haunt you if you ignore them or cause problems for the patient with soreness and red gums. You must manage the bone or the tissue will grow back. So people say, well, is that really true, and how do you know that? And is there any literature to support you? And of course the answer to that is yes. So let's take a look at some literature examples and see what they tell us about this very issue. Our Italian colleagues did an interesting study. And what they did was to simply take away the gingiva and reposition it back to the bone crest. And then they took measurements every few months, and at the end of a year, what did they find? Well, they found that on the buccal or lingual, the tissue had grown back to 3 millimeters. Interesting. That's the biologic width that we've been talking about. Interproximally, there is a difference. Interproximally, the papillae are somewhat pointed and capillary action changes them. So interproximally in the anterior region, if we probe that, we will find a 4 millimeter sulcus. But the basic number that we talk about mostly is the buccal, and that's the easiest to show you, and I want to give you some examples. Here's a very interesting case that we did a number of years ago. Temporary in place, gum shortened to expose decay, as you'll see here in a minute. So as we were taught a number of decades ago, that we put the soft tissue down here at bone level. But look what happens. After 3 months, the tissue creeps up closer to the margin of the temporary crown. And what happens? If you put the crown margin there too early and didn't wait for it to grow back, you would have a biologic width violation. So look what we're able to achieve. Subgingival decay, that was the problem that the dentist couldn't access, why he needed the gum shortening done. And once it's done, look at the beautiful margin, look at the beautiful healing of the bone, and look at, you can picture in your mind, I think, that there's enough room there for the soft tissues to reattach, for your impression to capture where the decay was, for your tooth preparation to eliminate it and have a predictable, healthy, stable, comfortable, and long-lasting result. So I think that you're getting a sense maybe already that gum shortening does provide solutions to some of the problems that we talked about earlier. The multiple impressions, the soreness, the impingement that causes the soreness, and of course the classic, I just had this crown made, why did it fall off complication. So let's look at some of these issues and how crown lengthening, or gum shortening as I like to call it, can provide solutions for you. Here's an example, and I think you can get a sense of the extreme extra amount of gum tissue that exists. You can actually, you probably can't see it too clearly, but here's where the soft tissue is on the x-ray. So get a sense, if you can, of what information we gather from that x-ray. As I said to you, I would like you to look at x-rays differently. Here's an example. This crown margin is 1, 2, 3, 4 millimeters away from the bone. That's a lot of tooth to be showing here. You can get a sense that there's way too much gum tissue, so maybe the preparation didn't go down as far as it could. So that's one hint, even from the x-ray, that there's too much gum. Here's the other hint. Without ever seeing the patient, you should be able to maybe get a sense from these two hints. There's decay there, and there's decay here under the crown. So if you're suggesting to the patient that they replace their crowns because of, quote, premature decay, I hope you also have the verbal skills to explain to them why it's so important to have a gum shortening to remove all that extra gum. It will increase your predictability, increase your ability to see what you need to prepare, and have predictable impressions every time. It'll help you to avoid these sore, inflamed gums. Joanne complained of these sore gums from the day the crowns were placed. And I'm sorry to tell you that her dentist, the same dentist as she'd been to before and continued to see for another 5 years, told her that it was because her flossing and brushing skills were inadequate. And yet she reports that the soreness didn't begin until the day her crowns were made. She said she went home that night and wanted with her fingernail to pull the crowns down because she said, I felt from the first minute that the anesthetic wore off that these crowns were up too high. Another example of crowns falling off because there's very little tooth structure, mostly buildup, no ferrule effect, and you can get a sense here of how much tooth is available if we just took away the extra gum. And solutions for remakes as well. This was in the laboratory that was in my building at the time. And this was back for a remake. And the instructions from the dentist were to the lab, please do not wax up the distal box area, as he called it, in quotation marks. Well, there is no visible distal box, and I don't know for sure where the margin is, and neither did the laboratory technician. So the question becomes in these situations, whose job was it to get a good result? Whose job was it to pick up this animal before the line was painted? Well, I don't know, but I do know that it's not the laboratory's job to make those margins fit. It's our job as the dentist to be sure that all parameters are handled correctly. So let me show you some examples, some clinical examples, and how you can get better predictability. Joan complained of soreness around her crown from the day it was placed. And if you've noticed, that's the pattern. All these people have the same story. It didn't start bothering them until that day. So she says, she comes into your office now. She's moved, and all these people that I see have switched dentists because they moved, the dentist retired, or they got tired of it like Joanne did with her sore gums. So Joan comes in and says, my gums hurt. right in there ever since the crowns were placed. And I will tell you that it's very, very important to tell her before you take off this crown, before you get started, that you can help her, and you're pretty sure you can, but Joan, there's the possibility you might not need another procedure. Again, Joan, there's the possibility that you may need another procedure called gum shortening for me to expose enough of your tooth. And there you have it. No tooth structure available at all on the mesial. So now if you want to go ahead and correct this for Joan because you've correctly informed her ahead of time and she thoroughly expects the possibility of another procedure, when you go in to do that, you must shorten the bone because you know that just taking the gum away, the gum's going to grow back. And you should expect to find, as we saw earlier on, the anatomical issue that causes the gum to be too high up around the neck of the tooth, namely in this case the palatal bony exostoses. So that now, after Joan's gums are shortened, there's enough tooth structure there to make a comfortable, pleasant, predictable, healthy crown. And I think you'll feel a good sense of satisfaction when you start doing these kind of cases. Another really interesting story. It's the same story. Larry comes into your office now the next day after you've just viewed this program. And he says to you, you know, ever since these crowns were made, my gums have hurt. And you take a look at him, and you take a look at the x-rays, and you are sure that what I've just told you is not correct. Because you can look at this and say, Larry, you have open crown margins. You have open crown margins. I can make you a better crown and more comfortably. Well, I think that you should consider being careful about that because when you take off the crown, you're going to have some surprises. So let's look at those surprises. First of all, if you'll notice that when those crowns are removed, Larry's gums immediately get better. You could say, well, see that? My crowns are going to do better. But if you also look further, you're going to find that there's very little tooth structure here. Very little tooth structure from the lingual. So you can understand our colleague prepping further down under here to get a grip on these preps. There aren't very many millimeters of tooth structure there for him to grasp onto. But when he does that, he violates the biologic width, and Larry's gums react accordingly. So what happens when we lift up the gum and we observe what's under there? Well, there you can see it. The preps are practically down to and touching the bone. Well, you know from our earlier discussion that we need at least 2 millimeters, and that's the absolute bare minimum, but we really need 2.5 to 3 millimeters from the bone crest to the margin of our preps. So you can see here this bulky bone, just like you saw earlier, and here you can see it removed, establishing more tooth structure. And if you'll notice that when the gums are put back, there's tooth structure there, there's tooth structure here, and in addition to that, there's a wide, wide open margin because your temporaries couldn't get down far enough to the prep. And as soon as they were placed short, that's why the gum healed. So what happens? Here's the prep that the dentist took a picture of for me after he prepped them. But here's what he had to start with if he hadn't asked for the gum shortening. And then the final result. Notice the tissue looks good. Here's how it looked originally. Notice that on the new x-rays there's no open margins, and Larry says that all of his discomfort is gone. So I hope that it's starting to make some sense to you now, and that you're starting to see the benefits of gum shortening and that you have an understanding of the measurements. Here's a very interesting story of Debbie and what happened with her and a dentist that didn't understand the measurements. See, Debbie came in with this bridge, and the problem was that it kept falling off. And her story was that she'd had a crown on this tooth here, and it kept falling off too. So the dentist said, well, your tooth is no good. It doesn't have enough there to sustain a crown. Let's extract the tooth. Isn't that disappointing? And let's put on a bridge. So they made a cantilever bridge that rests over here on the first bicuspid. But you know what? The cantilever bridge keeps falling off as well. And what I want you to start observing is x-rays. So if you're sitting in your consultation room with Debbie before you even go look in her mouth, and she tells you her story and asks if you can help, the answer would be, Debbie, I think so, because I think you have enough tooth structure here and here that we can correct this, and in the process, you may need your gums shortened to have more tooth exposed. I want you to see the bridge. I want you to see that Debbie's mouth is, you know, it's in reasonable shape. Her big problem is here with a missing tooth, which we eventually did an implant for. And on the other side, where she's got the bridge, you can see it's broken, and you can see how short this tooth is here, and you can see how really short this bicuspid was, because the pontic even reflects that. So how do we correct it? Well, you should already have a sense that it's a bone problem, not a gum problem. So here's the bone, the exostoses, and you can see it here removed. We did an implant instead of a pontic, but that's another story entirely. And here's what it looked like after 4 months. Notice that there's stability of the tissue. Notice that we took away some bone and it's nicely scalloped. Here's the implant. But here's the really exciting part. That's 4 months. This is 5 years. Look at the tissue. It's exactly the same. Look at the tissue on the palate. It's exactly the same. Even that little roll is still there. Solid, healthy, stable. Crown has never fallen off. So there's an example of how you can reverse her otherwise downward spiraling dental problems by using gum shortening. Here's the post-op x-ray at 4 months and 5 years. Notice the difference in the size of this crown now. You can see it's bigger because it grips more tooth compared to the original crown, where there is just simply too much tooth still showing above that crown, and it should give you a sense right away that there is too much gum. So now we're ready to look at the next step. If we have an idea that we need to take away the gum, how do we do it? The protocol includes full mucoperiosteal flaps with the appropriate amount of bone removal. And that's why you need to know and understand the measurements that we talked about at the beginning of the program on biologic width. In the posterior, our goal would be to have supragingival margins. Of course, we're only talking about non-aesthetic zones. In the aesthetic zones of the posterior or the anterior, certainly you would want to put your margins at 1/2 millimeter below the soft tissue margin. So here's an example with Kim. Her new dentist, it's always the new dentist, took her old crowns off and felt that the amount of tooth structure and the amount of preparation that was well subgingival was too much for him to be able to manage this without some gum shortening. So she comes over with her temporaries on already, and here's how we proceed. Notice the scalloping. Notice that it's slightly more as we get further back because we have bigger amounts of tissue, and we know that we have the deep subgingival margins here. Notice that on the buccal it's not as big because the buccal has a reasonable amount of tooth structure. The idea with your flaps is that they need to be thick enough at the margin so that the incision is made at a 35 to 40 degree angle, not straight up and down, because straight up and down will leave this margin way too thin and would almost certainly slough in the healing process. Most of us in our learning processes do that a few times in the beginning, and after 1 or 2 sloughed palatal flaps, you learn very quickly how to adjust your scalpel angle to have a nice thick margin here. So that now we want access to the teeth. And we want access, as you can see here, to remove this extra bone. Here's how much tooth structure there was pre-bone surgery, and look at how much was available post-osseous surgery. This will give you predictably greater amounts of tooth structure that you cannot ever get by just doing a gingivectomy. Notice also that the margin of the temporary crown did not reach the prep because it was too far under the tissue. Predictability is now guaranteed because you can see your margin 360 degrees, and you have the opportunity, if you wish, to have supragingival margins. This is a no-brainer on the lingual. There are burrs that you can buy that are end cutting, so that when you have the temporaries removed, you can go in between the teeth without nicking the adjacent teeth and reduce the bone to the level that you want. You want at least 2.5, if not 3 millimeters of bone reduction from the end of your prep, your fractured tooth, your old restoration, at least 2.5 to 3 millimeters, so that you can establish biologic width on the tooth and have enough tooth structure. And then when you go to the buccal or the lingual, you want to scallop the bone, now using round diamond burrs. I only use diamond burrs. I know carbide burrs cut faster, but they're much, much more difficult to control. They skip off the bone, they skip off the teeth, they gouge the teeth, and they can just jump off the tooth and dig into the tissue and rip it before you can stop. So I only use diamond burrs. And my goal here in establishing the scallop is that I want to mimic the scallop that nature gave us, as you can see here on another skull specimen. If we look at Brad, you can see the problems that he has with very excessive gum tissue. The margins are all subgingival, and it's not an aesthetic situation as you might think. This is purely a functional, mechanical, although anterior crown lengthening. And your goal that you want to visualize in your mind is what a skull specimen would look like with the natural scalloping and the rise and fall that nature intended for Brad. So it should not be a surprise when you lift the tissue up that Brad has very large bony protuberances. And that's what forces the gum up over this and way too high on the tooth. There's the turtleneck that I like to tell people exists. And there's what the bone looks like from underneath. And here's what it looks like after we've removed it. Once again, an illustration of the end cutting burr. And then on the buccal or labial, using the diamond burrs. We use an assortment of diamond burrs in different sizes, the end cutting burr, and I also have in my burr setup a long, skinny, narrow burr in case some of these teeth are just too close together to fit any of the other burrs into. So now you can see exposed margins, and you can see when it's healed for just a short period of time. It's probably, you can still see the suture marks, so this is probably no more than 3 weeks or 4 weeks, but you see tooth structure. You no longer have these buried margins, and you no longer have this big bulk of bone, because that's what causes the biologic zone problems. The tissue is just simply too high up, a turtleneck. So looking at the result from underneath, we've preserved the cuspid eminence, but we've reduced all the bulk. The dentist has access to the tooth to make non-biologic width violation crowns. And as I told you, this was purely mechanical because none of it shows when Brad smiles. So I showed you earlier with Kim a palatal flap and a buccal flap in the posterior. Sometimes these are a little difficult to reflect enough in order to provide adequate visibility of the bone. So I wanted to take a minute to show you what I do to create access. We may need a distal wedge behind the last tooth, often a second molar, not always easy, or we may use an anterior releasing incision, and we may, on the palate, do a vertical incision. that is really the only place where I use a vertical incision, because if you do it on the buccal, they're much more sore in healing. Here's what a distal wedge may look like. This is the case we looked at earlier with the very large bulk of tissue, with the decay under the two crowns, and the short margin here on the distal. Notice the distal wedge goes all the way up to about here. You can't really tell, but it does. Notice in a much more limited situation, it's a smaller distal wedge here. And I'll show you what that looks like. Here's the distal wedge again. And notice that it gives some mobility to the flap so that we can get our visibility and see what's going on underneath. And by taking out a wedge, when we go to close it, because we've now reduced the tissue, we've reduced the bone, everything's going to move apically, the distal wedge closes up. But we can only get that access by taking away some of the tissue. And here on a pig specimen is a couple of examples of moving further forward anteriorly to get good mobility of the flap, and sometimes even further forward. But the important point here is that you must have access. And on the palate, as I said, to get that flap mobility going, we may drop a vertical incision, but it's the only place because the palatal tissue is just too tough, too dense to be moving way forward with a sulcular incision, and yet we want access, so we use a vertical there. You know, people ask at all the courses about lasers and different technology, and can we just use lasers to reduce the soft tissue? Well, I say the answer is no, and you've already seen why I feel that way, because bone is the issue, and we know the body's going to reestablish its own biologic width. And here's an unfortunate example of Dara, who had a dentist remove, as he tells me, just a very, very small amount of gum tissue with his laser. But it took well over a year for the tissue to creep back. And I say that they really took away a lot of tissue, because look at the difference in size between her anterior teeth and her posterior teeth. If he really wanted, and if she really wanted, central incisors that long, they needed to do gum shortening and bone removal. It's the only way to have predictability. So we have to be careful with all our technology. Lasers, they're great. They have absolute places. They're going to be more and more popular. But do they replace the basics of ferrule effect? I don't think so. Bonded retention, will that overcome short tooth structure? I don't know. I see many problems. And remember the basics of biologic width, and I hope that you'll take that into consideration when you want to take your next technological shortcut. At the same time, I want to emphasize the fact that every tooth that you see may not be a candidate for gum shortening. The limitations are extremely important, and I want you to keep that in mind at all times. I'm going to give you some examples where we can discuss these issues with crown to root ratio. How about taking away bone and affecting adjacent teeth? Because sometimes the fracture is just too far down and we're going to affect adjacent teeth. We might also get into furcations if we're not careful. So I heard it said at a course, it was a very interesting comment, that if you have to spend more than 15 seconds debating whether or not you should do a crown lengthening or a gum shortening, more than 15 seconds, maybe it should be an implant. So it's a principle to keep in mind as you look at your cases and we look at these examples. Here's one that came to my office wanting a gum shortening. Look at the amount of tooth that's already been destroyed here. Can you imagine how far down you'd need to be here to have enough for ferrule on that root, to have enough for buildup, and to have enough for biologic width to reform? You'd be down here somewhere. You'd be destroying a lot of bone on the adjacent tooth and easily getting into the furcation. This tooth, maybe an implant would be better. I think that's probably the case. Compare that and contrast it to these two teeth. Notice that there is sound tooth structure above the bone. as opposed to here where there's no tooth structure underneath that crown. There's sound tooth structure, there's tooth structure up here, and so that by reducing the bone a little bit here, we avoid the furcations, we also create enough tooth structure that you have enough for ferrule effect without impingement and predictability. How about Susan? Is her tooth a candidate for gum shortening? She really wanted to keep it. It's very tempting, isn't it? But look at how short the roots are. Maybe it's not clear on the x-ray here, but this root is here, this other root is here. There's not much tooth structure, and if we're going to have enough for ferrule effect, for retention, then we may very well be more than halfway up the roots. So after much debate, we finally agreed that implants were better, and we put in 2 implants here and removed this tooth. A little bit of gum shortening on this tooth, and Susan has a predictable opportunity now to have crowns done without risking premature failure. So I hope that I've given you enough ideas that helps you to strategize the next time you see Larry come in with his sore gum tissue, or a variety of other issues like Susan with her very, very, very short tooth. Tissue impingement. I hope that you have enough ideas now to know how to avoid getting tissue impingement and have enough for ferrule effect for retention. And you have some ideas on whether or not you should retain a tooth, or maybe it's better off being extracted and have an implant placed. And you have some ideas now how to overcome the issues that I suspect many of you have experienced with failed impressions. And so that now you're ready. You're ready so that when Lisa comes into your office and says to you the same story that you've heard already, my gums have been sore ever since this crown was done. You could have a hint in the consultation room before you ever go into the clinical arena by looking at Lisa's x-ray, and you see tooth structure that sticks out from the crown. You can see a little bit of tooth structure, of crown structure being well under the gum tissue. And you could have a sense that she might have a biologic width violation. Here's what I want you to really be aware of. Before you take Lisa's bridge off, please tell her what we learned in dental school was inform before you perform. That yes, I can make you a better bridge, Lisa, but you have to also realize that you may need a procedure called a gum shortening, so that when you take Lisa's crowns off, you have told her before you took the crowns off that she might need gum shortening. Because if you don't tell her that ahead of time, and you take her bridge off and you see that tiny amount of tooth structure, well, now you're going to understand why there was this metal underneath the tissue and why there was this spur of tooth structure that didn't get inside the tooth, inside the crown, didn't get prepared because there wasn't enough access. So if you take that bridge off and you say, oh, now I understand the problem, now Lisa, we need to do a gum shortening, she could be understandably upset. My recommendation is that whenever you have a question about this, tell everybody before you take the crown off and you'll be a hero. So that you can see now the amount of tooth structure that's been exposed following the gum shortening. You can see the irregularity of that margin, and there's the little piece of crown that was burying under her gum tissue. And you can see the beautiful result with a supragingival margin, no more discomfort, pink stippled tissue, and a good result, and a predictable result as well. Now, if you think that you like these ideas, but that you might like to have some photographs to show patients, there are cards available from the Perio Academy. Their website is www.perio.org. org. Be sure to remember the org. And they have these cards, both on functional crown lengthening, showing something that looks pretty hopeless, but obviously there was enough of a root to do the gum shortening, and another card showing the cosmetic gum shortening that we have talked about in the other program. So my goal here, as I started out telling you, was that we want you to be able to have less stress, better predictability, fewer remakes, and happier patients. If you like these ideas, we hope this program is useful, but we're also willing to put together a hands-on course. So if you're interested, you should please contact the Global Institute. We think that gum shortening can help avoid these problems that we talked about at the beginning. Crowns falling off, sore gums, sensitive teeth, the surprise in the anterior like with Dara and her red gums, and the idea of premature failure or premature decay. So I hope we've given you some food for thought and some ideas maybe have crept into your own mind about how you would do things differently in your own practice. Because I can promise you that if you'll use these procedures yourself, or if you choose to work with your periodontal colleagues, that you will avoid these pitfalls and have a happier situation. In the anterior, there are some significant precautions, and I want to just mention them to you briefly. There is another program available if it interests you, because we have much bigger problems with red gums. The tissue in the anterior just seems to turn red more easily. The measurements are critical to 0.5 millimeter requirements, and smile lines are tremendously important in deciding ahead of time. If you get into this in the anterior, I mean, look at how exciting this is. For me, it was tremendously exciting to see Joanna before and after, and how we could absolutely change her smile and change the way she feels about herself. Look at all the gum here, look at all the gum that she shows, and look at how much more natural her teeth are. It's very exciting to be able to offer people these kind of aesthetic enhancements. Or Carol, you know, you think about anterior teeth when it comes to cosmetic gum shortening, but hers were really posterior teeth. And look at the difference in her smile. If she had only had the new crowns made and not the gum shortened, she could never have had the same kind of satisfying result. So as you've seen here with this example, I hope it's clear that sometimes gum shortening for cosmetic results can also be done on posterior teeth. If Carol had only had the crowns done and not the gum shortening, I think you would agree that her reconstruction would be less satisfying. Well, I thank you for your attention, and I hope that you've enjoyed the program. If you think that you'd like to know more about how to do these procedures, please contact the Global Institute, either by phone or by email at info@globalinstituteonline.com, and let them know of your interest, and we will put together a hands-on course for you. And also, I would appreciate it on a personal level if you would contact the Global Institute and let me know that you found these programs useful or that you didn't, because hopefully they will help to resolve some of the issues that we've been talking about at the beginning and end of the program. I thank you for your attention and look forward to your comments.